All right, the next section, we're going to talk about gestational diabetes. You are familiar with type 1 and type 2. I'm going to do a quick rundown because that will help in understanding gestational. Type 1 diabetes is thought to be autoimmune. It's more likely to onset in the first 20 years of life, and it is caused by the beta cells of the pancreas being completely eliminated. They no longer function at all. So a person with type 1 diabetes makes zero insulin. Type 2 diabetes it can be decreased insulin production. It can be increased insulin resistance. The tissues don't want to allow the insulin to get into the cells, or it can be a combination of both. So a person with type 2 diabetes still makes some insulin so they can get some glucose into the cells. Remember that the purpose or the function of insulin is to move glucose into the cells. So if we can't get glucose into the cells, we have to have alternate forms of energy. So with type 1 diabetes, we can have DKA because no matter what kind of glucose they can come up with, whether that's by what they eat or by breaking down glycogen or by breaking down amino acids, glucose still can't get into the cells, but they can break down lipids for energy, and that results in that has a byproduct of ketone bodies, which makes the blood acidotic. With type 2, they're less likely to develop acidosis. They're more likely to develop HHNS because the blood glucose keeps getting higher and higher and higher. So they continue to lose more water. The glucose in the bloodstream pulls water out of the cells, and then the kidneys allow that glucose to be eliminated, but it pulls water out through the urine as well. And so that patient will keep urinating until they're incredibly dehydrated. So that's type 1 versus type 2. Gestational diabetes is similar to type 2 diabetes, and it is actually connected with a later risk of developing type 2. Pregnancy causes increased insulin resistance, and that's to maintain enough blood glucose to supply the vital organs with energy, and also to provide glucose to the fetus for energy and for growth. So if someone has barely adequate insulin production, or they have some insulin resistance already, but they're not diabetic, pregnancy increases their insulin resistance more, and so that can lead to a temporary form of diabetes. So what happens? Glucose can't get into the cells. Blood glucose levels remain high. The cells break down fat and protein stores for energy. The breakdown of protein creates more glucose, which results in a negative nitrogen balance. So they're breaking down muscle tissue, but they can make some more glucose. Breakdown of fat leads to ketosis. Ketones are acidic, so that patient may develop ketoacidosis. Now in pregnancy, even though it's closer to type 2, they may actually have more ketosis because they have an increased energy need for the pregnancy. So the cardinal symptoms of diabetes, you're familiar with polyuria because the concentrated sugar pulls water from the tissues into the bloodstream. Then that glucose goes into the urine and pulls water with it, so they have increased urination. That makes them dehydrated, which causes polydipsia. The cells are starving, so we have increased hunger, and that's polyphagia. If hyperglycemia is severe, they may actually lose weight. That's not as common with gestational diabetes. You just need to know that it's a possibility. So what puts a patient at risk for gestational diabetes? Obesity, a prior history of gestational diabetes, glycosuria. If they've had a UA that had glucose in it, they've probably had some high blood sugars. A strong family history of diabetes, increasing maternal age. So those are the things that make it more likely to happen. If someone has gestational diabetes, they're at increased risk for developing type 2 later on. So maternal complications, the fetal blood glucose, the fetal urine output may be increased because of that increased blood glucose. The fetus actually has a pancreas that works, so all that extra glucose getting to the fetus, The fetus just produces more insulin to deal with it. But the fetus may have increased urination and have hydramnios, which can lead to premature rupture of the membranes. There's an increased risk of preeclampsia and eclampsia, which we're going to talk about in a later section. There's a risk of ketoacidosis. There's an increased risk of infection because of the glucose in the urine. So UTI and vaginal yeast infections are more common. And a patient with diabetes of any type is more likely to need a C-section. For fetal and neonatal complications, with poorly controlled diabetes in the first trimester, there's an increased risk of congenital anomalies. That's usually heart, central nervous system, and skeletal. Now, that's not gestational diabetes. That's someone who already had diabetes, they get pregnant, and they're not well controlled in the first trimester. Gestational diabetes tends to develop in the second trimester. There's a risk that the fetus will be large for gestational age or macrosomic. And that's because, remember, if the mother's blood glucose is high, that glucose goes to the fetus. The fetus has insulin and knows what to do with that glucose. So whatever is there beyond the fetus's energy needs just gets stored. So those babies pack on weight, usually around the trunk, and in particular around the shoulders, which leads to an increased risk of shoulder dystocia. Two babies of the same size, if one mother has diabetes, that baby is at higher risk for shoulder dystocia because of the pattern of weight gain. So that also leads to a risk of traumatic birth. Now, when that baby is born, the cord is cut or dries up and that glucose source goes away, but the pancreas, that newborn's pancreas, is still making insulin to cover all the extra glucose. So a newborn born to a mom with diabetes is at greater risk, or is at risk for neonatal hypoglycemia. Their insulin production takes a little bit to slow down. So we've got to really watch them really closely. If a patient has diabetes already and it's poorly controlled, we may have a big baby, but if it's severe enough and if they've already got some vascular damage from that vascular damage affects perfusion. So we can also see intrauterine growth restriction with a small baby, small placenta, oligohydramnios, because all of those have to do with perfusion. Again, that's not going to happen with gestational diabetes. That's more likely to happen to someone who has been diabetic and already has vascular damage. Newborns born to a diabetic mother may also have polycythemia. They may have jaundice, because once those extra red cells start breaking down, they have to do something with the bilirubin. They're more at risk for preterm birth. Now, this is interesting. Remember that the babies grow bigger and the placenta starts to give out sooner because of the vascular effects of high glucose. So we've got a bigger baby, placental insufficiency, placenta gives out sooner. So we want to get the baby out a little bit early, right? Except that insulin also, remember the baby's got lots of insulin because of all the glucose. Insulin also suppresses lecithin, which helps with lung development. So they have delayed lung development, but they're larger and the placenta is giving out sooner. So delivery needs to be kind of a balancing act of those things. And because of the potential for placental insufficiency, the baby, the fetus with the mom with diabetes is at risk for intrauterine fetal death. Management, first of all, is testing. Late in the second trimester, it's standard to have a 1-hour glucose tolerance test. If the patient fails that one, or they have more risk factors or a history of diabetes, they do a 3-hour glucose tolerance test. At the 2-hour mark, don't want to tell you wrong. I'm not going to test you on the specific number, but they're looking at that 2 and 3 hour mark, what the glucose is. Hemoglobin A1C is used for management, but not for screening. So how is diabetes managed? The first option for gestational diabetes is managing by diet. The calories need to be based on that patient's ideal weight plus their pregnancy needs. So we don't want to cut calories unless that patient's just consuming a lot of excess. About 45% should be complex carbs, 20% protein, 35% fat, and that needs to be divided through the day into about 3 meals and 3 snacks. The bedtime snack is the most important to prevent late night hypoglycemia, which can actually cause the blood glucose to go back up first thing in the morning because it's they're trying to compensate for their body's trying to fix that 2 a.m. low blood sugar. A lot of patients do carb counting and just manage their gestational diabetes that way. Glucose should be monitored in the clinic, but it also needs to be monitored at home several times daily in relation to meals to make sure that that patient is maintaining blood glucose within an acceptable range to prevent complications. If diet and exercise don't maintain blood glucose levels, then insulin is given, generally human insulin. That can be multiple sub-Q injections per day, which for gestational diabetes is going to be the most common. They can use a pump with continuous sub-Q. Remember that if they're getting continuous insulin and they miss a meal, they're at risk for hypoglycemia. Historically, oral hypoglycemics were not used in pregnancy, but some of them have now been tested. So we're starting to see a little bit of oral hypoglycemics used in pregnancy. The patient needs to be monitored more closely for those fetal complications. So they're going to do the alpha fetoprotein at 16 to 20 weeks. They need an ultrasound at 18 weeks for dating and anomalies, because remember, some anomalies are higher risk. Around 28 weeks for growth. In the last few weeks of pregnancy, they're going to get BPPs and NSTs to make sure that the placenta is holding out okay. From about 28 weeks on, we want fetal activity monitoring by the pregnant person. If they have a non-reassuring, non-stress test, the provider may go ahead and deliver, or they may do a contraction stress test and see how the fetus handles contractions. If they're hospitalized for reasons related to the pregnancy or diabetes, they get a daily NST and BPP. Labor management, one of the most important things is timing the delivery. The provider doesn't want to wait too long and risk intrauterine fetal demise. They also don't want to deliver too early because remember, the lungs are less developed and risk respiratory distress syndrome. So they're looking at how do we deliver this baby at the optimum time. Remember, the baby may be at risk for intrauterine growth restriction or macrosomia. So they look at if that baby is not growing well, they probably want to go ahead and deliver. They also look at, is this baby getting too big to safely deliver? They look at the mother's vascular disease, if they have any vascular disease and how severe that is. They look at fetal lung maturity. And remember that they can do an amniocentesis for fetal lung maturity late in pregnancy. Preterm birth, either induced surgical or sometimes spontaneous, is common for fetal indications, or it's common in diabetes, but it's very common to have these babies be born preterm because the baby needs to be delivered. In labor, insulin requirements decrease. So if the patient's been taking insulin, we need to be monitoring them closely in labor because during labor, they're going to need less insulin and we can make them hypoglycemic. If there's a risk of not being able to maintain stable blood glucose easily, they may have an insulin and D5 drip. I've not seen that for gestational diabetes. It's probably more likely to be used for a patient who has like a brittle type 1 or who's been on insulin long-term with type 2. But they may do an insulin and D5 drip that can be titrated. Those need to go in separate IV lines. Insulin needs to be piggybacked into normal saline at the nearest port to the IV site. When you're doing an insulin drip, it's really important. When you're doing an insulin drip, you add the insulin to the bag before you prime the tubing. So I want you to think about this, and I want to try to find a way to do this in lab for Wilburton. We can do this at Audubon, but I want to try to find a way for you to see this in lab. Think about adding insulin to an IV bag that already is the tubing's attached and it's already primed, and then you add the insulin to the bag. Okay. And then you're going to run that insulin at maybe 3 milliliters an hour, because that's, you know, how you're going to get the appropriate dose of insulin. How long will it take to get the insulin to the patient at 3 milliliters an hour? So you're looking at hours before the patient even really starts to get the effect of that insulin. So you flush the, add insulin to the bag before priming and flush the tube with insulin. Let a little bit of it run out, because insulin also binds to the bag and the inside of that tubing. In the second stage, they may not need insulin. So we need to be monitoring really closely in the second stage. And then after the placenta is delivered, that insulin drip is stopped. And then the patient's going to be monitored closely during the postpartum recovery. Mild gestational diabetes may be managed just by monitoring blood glucose in labor and making sure they're getting adequate glucose intake. Okay, in the next section, we're going to talk about another long one, preeclampsia and eclampsia.